مساء الخير عليكم جميعا. احنا we're very pleased to start the luminal breast cancer session. Luminal breast cancer session I'm going to co-chair with the first session on CDK4/6 inhibition in advanced breast cancer. Professor Dr. Nirvana Magdi, and Professor Dr. 𝐜𝐚𝐧𝐿, Professor Dr. Nuran Ruby. Where is 𝐜𝐚𝐧𝐿? يلا.
بسم الله الرحمن الرحيم. مساء الخير على حضراتكم. أحب أقدم لكم نفسي. أنا دكتورة نوران الروبي. أنا زميل تمام. أنا دكتورة نوران الروبي. أنا زميل علاج أورام في مستشفى أحمد ماهر التعليمي، ويشرفني وجودي وسط حضراتكم النهارده، وشكرا لدكتور أحمد عبد الهادي لإتاحة الفرصة إن إحنا وشكرا لدكتور حسام ودكتورة نيرفانا إن هم معايا في السيشن النهارده عشان نتكلم على الديفرنت امباكت والديفرنسز بين CDK4/6 inhibitor في الادفانسد بريست كانسر كيسز. احنا عندنا اول حاجه ان الHER2 positive breast cancer disease بيبقى around 70% of the breast cancer cases، والمفروض ان احنا في الحالات الميتاستاتيك we are totally الجهود بتاعتنا toward the balance between the quality of life وال quantity of life وبالانسنج للافيكاسي versus التوكسيسيتي regarding improving the survival وان احنا نعمل delay للديزيز progression وال duration of the response with palliation للsymptoms. على الرغم من انه الهرمونال تريتمنت ليه رول قوي قوي في البيشنت اللي هم الهرمونال دريفن بريست كانسر كيسز، بس الاندوكراين ريزيستنس بتديفلوب سواء كان عن طريق loss of the estrogen receptors في الابيجينيتيك تشينجز او ER mutations اللي بتحصل، او بيبقى في cross talk between others receptors والcell cycle promoters والstimulations of the cyclin dependent والinhibition of the retinoblastoma pathway والتشينج في التيومر مايكرو انفايرمنت. التوك بتاعنا mainly عن الرول اوف ذا CDK4/6 inhibitor اللي هم بيعملوا تارجتنج لل CDK4 في الHER2 الهرمونال ريسبتور HER2 نيجاتيف كيسز. وبيبقى فيه وزي ما كنا بنتكلم انه في a lot of potential mechanism resistance بتحصل لل CDK4/6 pathway. مهم ان احنا نعرف انه المولكيولز نفسها بتاعت ال CDK4 inhibitors في differences بينهم عن طريق انه الرايبوسايكليب والابيماسايكليب بيبقى selective toward ال CDK4 اكتر من ال CDK6، والابيماسايكليب بيعمل inhibition لمالتيبل اوف كاينيزز، وهي ده اللي بيخلي انه في توكسيسي بيظهر فيها دايريه اكتر. واكيد برضو انه حضراتكم عارفين الفروق بين الديفينيشنز بتاعت الاندوكراين ريزيستنس، وهي دي اللي بنبني على اساسها الديسيجن في اختيار السي دي كي 4 زي الاندوكراين سنسيتيفيتي والبرايمري ريزيستنس والسكندري ريزيستنس. وريجاردنج الانفلونسز بتاع التريتمنت ديسيجن النهارده هنتكلم مع حضراتكم على الافيكاسي داتا فور ذا CDK4/6 انهبيتور في الفيرست والسكند لاين. اتفضلي دكتوره نيرفانا.
صباح الخير جميعا. طبعا يعني صباح الخير ولا مساء الخير. طبعا شكرا دكتور احمد الهادي و all the organizing committee for inviting me today. Thank you chairpersons طبعا Mr. Chairman for introducing me. خلينا نتكلم بس احنا النهارده ده المفروض ان kind of debate. We have three main players for the CDK4/6 with some differences in between. فهنتكلم المفروض انا وزميلي العزيز دكتور حسام الزوام ان هنتخانق ولا لا فخلينا نبتدي من الأول efficacy data. Which of them we have 3 main players. These are all the clinical trials which have been done, the MONALEESA 2, MONALEESA 3, MONALEESA 7 in terms of the ribociclib, the MONARCH and the PALOMA in terms of the PALBO and the abemaciclib. So which of them in terms of efficacy? As you see here, in terms of the progression-free survival, the hazard ratio between the trials is almost very comparable. بنتكلم hazard ratio 0.563, 0.5, 0.5. So we don't have a differences in PFS. However, if we go to the overall survival data, you can see that the consistent overall survival data was in terms of the ribociclib, because it showed an overall survival data in MONALEESA 2, in MONALEESA 3, and MONALEESA 7. And the MONARCH 2 in terms of the abemaciclib, there is a significant overall survival data in the MONARCH 2. However, in the MONARCH 3, it was just numerically difference with no statistically significant. And the PALOMA الحقيقة, they didn't show an overall survival data. طب what is our conclusion? If I am, لو أنا بدور العيان بتاعي, if I need an overall survival benefit, اللي عندي data with consistent overall survival data along the all trials is the ribociclib. If you want, and with the abemaciclib, we have some data about the overall survival data. However, in the palbociclib, we don't have a solid data about the overall survival benefit, but we have an equivalent almost PFS along all trials. What about the second one, which is the size of disease and overall tumor burden? If we have a visceral disease, will one of them will be more active than the other? دخلنا subgroup analysis in the PALOMA and the MONALEESA in the palbociclib and the ribociclib. زي ما حضراتكم هتشوفوا في البالوما هتلاقوا ان non-visceral are working better than the visceral with a hazard ratio 0.5 versus 0.6. So in PALOMA the non-visceral are working better than the visceral. However, in the MONALEESA الاثنين تقريبا زي بعض with the same hazard ratio, and the same for the MONARCH. However, there are some data that the overall or the response rates in the visceral disease with the abemaciclib, it almost reaching 60 to 62%. So if you have a visceral disease, you can think about the abema and the ribociclib. The abema, yes, it showed benefit. However, the benefit was more in the non-visceral disease. وهنجاوب هنا برضو هنextract from the clinical trials الكلام اللي احنا بنقوله ده مظبوط ولا لا. طبعا كلنا عارفين الرايت choice study دي كانت phase 2 trial اللي كانت بتشوف whether the ribociclib versus البيشنت اللي عنده heavy burden of the visceral disease versus the chemotherapy. ودي كانت there is a clear PFS benefit in terms of the ribociclib versus the combination chemotherapy. وكانت البيشنتس اللي كانوا عندهم visceral disease especially the de novo كانوا they show a good responses. Again in the ESMO 2024 في the ABI-JAIL trial عملت نفس الكلام phase 2 trial بس concerning the abema. What about the abema versus the chemotherapy which will be working better? وكانت هنا بقى البرايمري اند بوينت بتاعها كانت 12 week overall response rates. شافت الريسبونس ريتس باعتبار ان دي patients عندها visceral disease والريسبونس is very important. فشافوا ال 12 weeks response rate in the abemaciclib will be comparable to the chemotherapy or not. فهنلاقي هنا ان احنا تقريبا almost 60% من ال patients اللي كانوا على abema and endocrine therapy they show an overall or reach the primary endpoint versus 40% in the patients who receive paclitaxel. And the conclusion of the trial, it was that the ABI-JAIL trial met its primary endpoint with a 12-week overall response rate of about 60% versus 40% in terms of the paclitaxel. Toxicity profile observed after the first 2 weeks was as expected. The ABI-JAIL trial demonstrated that abemaciclib combined with endocrine therapy show a superior efficacy at 12 weeks compared with the standard chemotherapy, especially in patients with aggressive disease. This study currently is ongoing to evaluate the long-term efficacy and other secondary endpoints. So from here نقدر نقول ان احنا عندنا data ان in the patients with a heavy burden disease or a visceral disease, abemaciclib is working very well with a good overall response rate. Yes, it is a phase 2 trial. However, we have some data, and the ribociclib still it is working also very well in the visceral disease. However, in the PALOMA trial, it shows that the patient with non-visceral, yes, it worked in both. However, the patient with non-visceral disease was working better than the visceral. What about the third one? My colleague, Dr. Hussam, please go for the toxicity profile.
Thank you so much, to Nervana. Very impressive data regarding the differences between the different CDKs. يعني looks like we have a winner. يعني all the data اللي قالتها لنا دكتورة نيرفانا regarding the efficacy and regarding the sites of the disease, looks like we have a winner regarding the ribociclib. But let's see what will be different in the other factors that will influence the treatment decision. We'll talk about the toxicity profiles. We know that the toxicity profile of all the CDKs include neutropenia, some cardiac efficacy, which is unique to the ribociclib, the GIT manifestations, and the liver functions and other side effects. They are combined with all the CDKs, but with very different rates. Regarding the neutropenia, the palbo and the ribo have the highest grades of neutropenia, while the abemaciclib in the monarch has just a bit lower rate of neutropenia. The QTC prolongation is unique to the ribociclib. So with the ribo, you have to do ECG regularly. The GIT manifestations is unique also. Not unique, is much more higher for the abemaciclib because it's a different profile or different mechanism of action, as illustrated by Dr. Anwar. It has different inhibitors of multiple CDKs other than the CDK and 4/6. The liver toxicity is higher in the palbociclib arm. And this different toxicity profile makes us do some more monitoring and follow-up examinations and investigations. For the ribociclib, you have to do ECG at the baseline cycle 1 and plus or minus cycle 2. You have to do the electrolytes, the sodium, potassium, and the magnesium. You have to do regular liver functions. For the palbo, you can be a bit relaxed about the follow-up pattern. It is the simplest form of follow-up, just CBC. You don't need other investigations more that regular. For the abemaciclib, it's somehow in between the palbo and the ribo. You have to do the functions, but you have to be very cautious about the diarrhea and the GIT side effects. The fourth factor, the menopausal status, and the menopausal status, we have a very clear leader in the menopausal status because the ribociclib is the only CDK that has a specific trial that is unique to the pre and perimenopausal patient, which is the MONALEESA 7, and the results of the MONALEESA 7 were much in favor of adding ribociclib to the endocrine treatment in these premenopausal patients, with similar efficacy regarding the visceral or the non-visceral disease. The fifth item is the CNS activity, and for the CNS activity, you don't have a very clear or solid data, just like the other parameters, but the abemaciclib has the best CNS penetration, and there is some data about the crossing blood-brain barrier and documentation in case of intracranial diseases and in case of leptomeningeal diseases in favor of the abemaciclib, while the palbo and the ribo have just some limited data about their CNS activity. The sixth item is the sequencing, because if you start with an AI only in the first line setting, for the second line you have to give fulvestrant plus CDK, and these are the three trials that combining the fulvestrant plus CDK, the Paloma 3, MONALEESA 3, and Monarch 2, and they all have consistent benefit regarding the addition of the CDKs. But we have to appreciate that comparison among trials is not easy or is not the right thing to do, because they have different patient population. For example, in the Paloma 3, they include 30% of cases which have received previously chemotherapy. This is not the case in the other two trials, the MONALEESA and the Monarch. But the data regarding the PFS was similar in favor of adding the CDK to the fulvestrant. For the overall survival, the palbo is not significant. It is numerically higher, but it is not statistically significant. But while for the ribo and the abema, the data is significant regarding the overall survival, just like the first line as illustrated by Dr. Nervan. Then if you give the first line AI plus CDK, can you shift or can you re-challenge with another CDK plus fulvestrant? We have three trials in this setting: the maintain, the post-monarch, and the PACE. The PACE is negative, so we'll not talk about it. We have the maintain and the post-NORC. The maintain brought patients with endocrine responsive metastatic breast cancer, endocrine sensitive metastatic breast cancer patients who received first-line CDK plus endocrine treatment. The CDK was mainly palbociclib. They shifted to ribo plus fulvestrant, and the data was in favor of the palbo arm. For the post-NORC, similar patient population, but different CDK inhibitor, the abemaciclib plus the fulvestrant versus placebo plus fulvestrant, and the data was also in favor of the abemaciclib arm. But we should note, in these two trials, we have very early relapse in the first 6 months, in both arms, in the CDK arm and in the fulvestrant arm. Very early relapse in the first 6 months. Perhaps identifying biomarker data will allow us to know exactly which patients will progress rapidly in the first 6 months of treatment. So to conclude our talk, we have the ESMO guidelines and all the guidelines established in the metastatic endocrine positive breast cancer patients. You have to start first line with endocrine treatment plus CDK, and the scenario or the selection of the CDKs depend on many factors. If you need strong evidence regarding the survival, you will choose the palbo, as said by Dr. Nirvana. If you have visceral and aggressive disease, you have to choose either the ribo or the abema. If you want an easy monitoring and follow-up, you can pick the palbo. In premenopausal patients, the data is only in the ribociclib arm. Brain metastasis, abemaciclib. Concern for neutropenia, abemaciclib also. If you have concern for diarrhea, you should not choose abemaciclib. If you have concern about the cardiac toxicity, you should not choose the ribociclib. And thank you so much.
Thank you, Professor Hussam, Professor Nirvana, Professor Nuran. My just point, a very small point, that the OS have been gained in the Mona Lisa. That's absolutely right. But we have not to forget that the Paloma was the first drug and study evolution, where they recruited much more patients with primary resistance, much less sample size, so and much more drop off of the treatment. In the Paloma, they revealed a lot of drop off of the study. So that's why they did not achieve the OS. The
patients in the Paloma may be a bit higher risk than the other studies. For the Paloma 3, for example, they have some patients with who previously received chemotherapy. 30% of cases.
We need to know your experience, Dr. Tamer. If you have the 3 players and you have a patient, which patient fits what? Excellent. I know that there is different patient criteria and there are different toxicity profiles and different patient profile. How do you think about the patient when it comes for the first time?
When we look at the real world data, regardless of the randomized trial, we're going to find that they are completely equivalent, completely identical. The first trial was palbo, because it was the first evolution of CDK4/6 in the armamentarium treatment of luminal breast cancer. Then came the abema, then came later on the ribociclib. The ribociclib was a very selective trial, much less primary resistance. So this is always, when you go evolve with different trials, you get to understand what happened previously and avoid it. So my point of view, if we look at the real world data, regardless of the randomized trial, they're very identical. It's proven, it's published everywhere. And the 3 trials, the primary endpoint was reached in the 3 trial, yet the OS was different in view of the selectivity, in view of the sample size, and so on.
في another item برضه هيخلينا choose the treatment, البرايس يعني.
This is a different, of course, yes. Thank you very much.